Is Levi Davis. I'll be presenting my portfolio and my PDSA project. This is my electronic portfolio. It's on LinkedIn. It kind of looks like a Facebook, but it's more business oriented. It has my employment and who I'm affiliated with. It has a little about me section, pretty much saying that I've been a nurse 3 years. I work at Lakeland Regional in the critical care services. I was a bedside nurse and a relief team leader on MICU, and I currently work for CCAT, the rapid response team. I have some emergency room experience, and I also am enlisted in the Army Reserves currently. I attended basic and advanced individual training and became a certified pharmacy technician. Once I've completed my bachelor's, then I can go ahead and be commissioned as a nurse in the Army. So here's my experience. This is my soldier experience, and then my experience here at Lakeland. I've been there 5 years. I was a PCA for 3. Education, I got my liberal arts degree from Polk State, and then I went over to HCC and got my EMT paramedic, and then I came back to Polk State shortly after to do the transition bridge and get my associate in science and get my RN. So this is my license and certifications here. It's got my RN and then all of our IHI certifications that we did over the course of the BSN course. The cool thing about LinkedIn is I can get my resume from here. It attaches my LinkedIn to it. It has my email, that same summary that I read earlier, and then it has my experience listed there, my education, and my license and certifications, which include PALS, BLS, ACLS, and my credentials here that were on the other page. And awards go on the bottom. So that's my professional profile. Get to my PowerPoint here. So currently I work for the CCAT team, critical care assessment team at Lakeland Regional. It's the rapid response team there. It's a group of selected experienced critical care nurses, and we assist triage and help facilitate care on the floor. We're kind of a liaison between acute care and critical care services. The acute care nurses normally call us, or anywhere outside of the ICU can call us if they're concerned with somebody or a patient, and we go and assess them and see if they need critical care services. It's a fast-paced environment, and it requires a lot of critical thinking, which leads me to our area of improvement, which would have been communication. I feel like our communication is somewhere we can improve on this team. So between our members, between shifts, doing the interventions, following up with those nurses on the floor, rounding on patients that we've seen or that we know that have come out of the ICU and could potentially go back. There's just no standardized way of doing our report in CCAT, so I wanted to try to streamline that. My theoretical basis for this project came off of Florence Nightingale's Notes on Nursing, observation of the sick, pretty much observing, finding out what's important, finding out what's not. Was there neglect or is there not? It's just pretty much our basic observing and assessing and following up on things, which is CCAT's role. We got to verify that the accurate information from the floor nurse, from the family, from the patient, making sure that everything's accurate. Looking at current trends in the chart, if a patient is possibly septic and they're normally running like their blood pressure from 150s to 160s and now they're low, doing like 100, 110, we know something's deteriorating there. And so we're looking at trends for improvement or decline. And then we're following up with these nurses and following up on any interventions that we need. So through my literature review, I did evidence-based research. Part of my paper was on importance of having a rapid response team. IHI actually has a 100,000 lives campaign that is for initiating a rapid response team in the hospital and trying to save those. They said that if with an initiation of a rapid response team, we can prevent further deterioration into the ICU or prevent cardiac arrest. The online Journal of Issues in Nursing, they're saying that the rapid response team is practically mobilized critical care. You're bringing the ICU to the patient instead of getting the ICU or getting the patient to the ICU. These nurses are able to go in and assess and treat these patients on the floors with ICU intervention and then get them to wherever they need to go. Journal of Med-Surg Nursing, they did a retroactive study and looked at cases of cardiac arrest in hospitals outside of the ICU compared to after they initiated a rapid response team. They saw a reduction of 50% in both studies of the cardiopulmonary arrest outside of the ICU, which is amazing. And then I went on in my paper about standardizing communication, high quality of continuity of care. That's important. We need to, because if I'm coming off shift at 6 and I'm treating a patient, I don't say anything to the next nurse that's on CCAT and they just show up and they have no idea what's going on. There's no continuity there. And that's really important, even with the CCAT role. Effective communication with everybody on the floor, to the doctors, respiratory therapists, other nurses, family, patients, and attentive listening to all of those. Those are important. And I put in some research articles from people on our Polk State database. Some of them talked about how standardizing communication causes a clinical surveillance. That's pretty much how I like to think CCAT is. We're kind of surveying the hospital, seeing which patients need to go to the ICU or not. And then the AACN synergy model talks about how communication is productive and helpful. So for my PDSA project, my objective was to improve the CCAT handoff report and improve reassessment of patients that have required a CCAT response. The goal is to achieve that early goal-directed therapy, prevent reoccurring CCATs, because we get paged often and sometimes we get paged back-to-back on the same patients. We want to have the ability to track these patients that have required a CCAT response. So that's why I'm going to implement the CCAT communication form. It's a shift-to-shift electronic form that can be used by anybody. It can be pulled up through our shared drive from any computer in the hospital. It has patients' informations like their name, room, code, status. I think the MRN's on it as well. There's a section where we can put interventions follow-up. That's kind of the section that we can pass along, like, hey, this is what I've done. You're going to need to go look at this patient. Or, hey, I looked at that patient from last shift. I think you should still keep looking at them. Or if they're doing better, then we don't have to. And that's that rounding. And it prevents prevented CCATs with us keeping up with these patients. So this is the rounding form. This is the blank one. This is where I started when I was implementing this. So I went in at day shift and night shift on my clinical days to watch for 2 hours. I came in an hour before and stayed an hour after shift change, helped the CCAT nurses understand this form and how to use it and how to access it, and then watched them use it through those hours as well. I was able to watch them do it. And then this is my cycle 1 and cycle 2. So the first cycle, we did that exactly what that other form was. You can see I had to blur them out because of HIPAA, but you can see the different calls that they had those days, and then the patient's name, MRN, and then the concerns and intervention. So it pretty much gives a little synopsis of what's going on with the patient, and then if the CCAT nurse on the next shift needs to follow up with that patient. So for PDSA 2, we added a COVID-19 rounding because of COVID and CCAT's involvement in these patients, and now we're expected to round on these patients. So we added that to the bottom through our second cycle, and it really worked out well. So it's the same thing across on the top, except they added a round 1, round 2, because now they want us to round twice a shift on these patients because they're trying to track what's going on at the hospital. So that helps us remember, hey, we need to go round on these patients. And then there's the next column that says follow up as the first one. So the bottom, that one pretty much just goes more into detail with COVID, if they're positive or rule out or negative. And then it tells you their current oxygen settings. That has come really helpful to us because now even respiratory is using it. So outcomes, CCAT's still using this form. We've been using it every day that I come in. Everybody's using it and everybody's loving it. They're actually talking to IT about getting it more easier to use. It led to the creation of a shared drive for CCAT. We didn't have one before to where we could share things through it. So that's not only helpful for this sheet, but for other things. It's now multidisciplinary. Doctors use this when they're doing the trials on the COVID patients. They use that bottom portion for COVID rounding. Our respiratory therapists use this as well. So does our sepsis coordinator, and some of our clinical quality people look at these sheets as well. Strengths of this project, we had collaborative team members. Everybody was involved. It improved in communication between the shifts. And I believe that we have a better picture when we come on shift of what's going on in the hospital. And it created accountability and continuity of care for these patients and accountability for us to follow up with them. A weakness that I identified was there was newer and experienced team members with COVID. We've had a lot of new people come on, so they're still trying to get their feet under them. And then the paper doesn't actually show the whole clinical picture was another weakness that I identified. You have to kind of go into detail and then they have to remember it, but we're working on it. So self-reflection through this PDSA project, I learned leadership skills to implement change. I've never changed anything in an environment before, and that was pretty cool to watch the change and actually still being used. So that proved leadership skills there. Using evidence-based practice and research, that's a tough one for me. I really grew in that doing this evidence-based practice, and it was something that I actually enjoyed writing on, and I felt like I could research better. Through the BSN program, I've grown personally and professionally. My strengths are leadership and communication that I've found through this process here at Polk State. And then my weakness would definitely be that theoretical basis and evidence-based research. I had a tough time in those classes a year ago. I remember struggling through those. But I feel like this BSN program has made it better for me. I know how to use the database now. I know how to make an evidence-based article, and I definitely know how to do APA now for sure. My future goals for myself, short term, like within the next year, I want to do my CCRN, get that completed. That's the critical care registered nurse certification. And I want to commission as a medical officer in the United States Army. So hopefully that can happen this year with them. Long term, I want to do MSN, MBA. I want to be a nurse administrator. That's the big goal. Thank you for listening. I appreciate you guys. Thank you, and I wish you best in your endeavors.